Hey everybody, we're going to talk real quickly about Chapter 6, Communication and Physical Assessment of the Child. So when we're talking about communicating with the pediatric patient, we also have to talk about communicating with their parents. We talked about that a lot last week in our first class about how it's taking care of the whole family. Um, and really, this is from somewhat of an outpatient setting, but when we're talking to parents in the hospital setting, one thing you guys have to keep in mind is that they're sort of out of their element when they're in the hospital. Their child's sick, they're out of the norm, they're out of their routine, so they may actually not be very talkative. And so as we encourage them to talk when they need to, when they're ready to talk, um, encourage them to express sort of their feelings, and then really listening and showing that empathy is really a big part of pediatric nursing. When we communicate with the children, obviously we communicate with them on a developmentally appropriate level. So we're talking to a 2-year-old very differently than we're talking to a 10-year-old. We like to get on their eye level. That evens the score. It helps them sort of allow us into their world. Um, we should be very quiet, very gentle, very slow when we're approaching kids that don't know us. It's important that we take our time to let them just sort of trust us. And you'll see that in the clinical setting. Your patients will begin to trust you throughout the day. The more they see you, the more they interact with you, they'll be better at trusting you. Um, One thing that we always try to sort of avoid is like analogies or metaphors. And anybody who's been around kids understands that they take things very literally. We want to give clear instructions. We want to tell the truth. One thing that I'm a huge supporter of is really telling them the truth. So when they say, "Does it hurt?" We don't say, "No, it's not going to hurt. It's not going to hurt." No, we actually say, "You know what? It might hurt." But this is something we have to do. And so we're just going to get it done and so we can move on. And kids are very resilient and they respond well to truth. And so it's important to do that. Not use medical jargon, don't use scary words. Oftentimes we don't even talk about things in front of kids if they're a certain age. We'll go out to the hallway and talk to the parents about it. So we don't scare the kids. Yeah, that literal or interpretation. So just a small stick in the arm, they actually envision a stick in their arm. So with infants, they're nonverbal. So we're listening for their types of cries. How are they able to communicate with us? Well, the only way they can tell us is by crying, or by being happy that they're comfortable, their pain's under control, and things like that. Um, Early childhood, we want to communicate with them clearly. We want to explain as much as we can very concisely. So we want to answer their questions. We don't want to belabor things, but we want to answer their questions very sort of briefly but succinctly. Um, Use words they'll understand or that they'll recognize, um, and really being consistent. This one makes me giggle a little bit, but it's true. You know, when they're getting an IV put in, don't smile at them and say, "Oh, it's okay, this is fun." You know, no, this hurts. It's okay, it's almost done. You're doing a great job. Just be truthful and sort of match your expressions with what's going on in their world. Um, and then adolescents, honesty, 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 privacy. Those of you that went through pediatric orientation, we talked about that. Um, Developmental regression may occur, and then sort of respecting the importance of of their peers, and their friends may visit the hospital and things like that. Okay, play is the work of children. It's what they do, it's what they are innately programmed to wake up and want to do. Um, it's therapeutic, it's a stress reliever, it's a pain reliever. It really is a barometer of illness. If a kid is playing, it's a good indication that they feel good today. Um, we want to encourage play. We want to give them opportunities to play even in the hospital. You're going to experience this. There's playrooms on every floor. They have things in their rooms that they'll play with. Child Life will bring in toys that are appropriate for their developmental level. That's one thing that you might be tested on is various developmentally appropriate toys that would be appropriate for a child to play with in the hospital. So keep that in mind. Play is very, very important. Um, when you're approaching the child for a head to toe assessment, sometimes we sort of differ in how we do our assessments. You might do them a little bit more out of order, depending on what's appropriate for the child. It actually may be broken up. You might have to do it in stages because the child's not cooperating or the child's in the playroom or things like that. So just keep that in mind. You really want to minimize stress and anxiety when it comes to assessment of the pediatric patient. You'll see in clinical that sometimes our assessments are very abbreviated. Um, if you have a child who is in for a basic appendectomy, laparoscopic, you know, very minimal invasive procedure now, we're not doing an entire head to toe with a full neurologic exam and things like that. Your assessment is going to be tailored to your patient and to your patient's diagnosis. So keep that in mind. Um, One thing, and we shouldn't do this with adult patients either, but we always warn them. We give them time. Our pediatric assessments of our adolescent patients, particularly on the oncology floor, oftentimes they might not happen until 9 o'clock if they've been sleeping. We're not going to roll them over and say, out of bed, let's do your assessment. You really give them a little bit of control, and that's important. Preparing the child really enhances their cooperation. The parent's presence is always is good to be there, um, and then those age appropriate techniques as well. So one thing that we did touch on this in pediatric clinical is recumbent length for infants up to 3 years old. So that means we're laying them down um, and we're measuring their length. Then after 3, then we can do a standing height. Okay, but until they're at least 3 years old, then we do that recumbent length. We're plotting everybody on a growth curve. We also talked about that in pediatric orientation for those of you that are in clinical this 8 weeks, and I'll teach you how to plot those things later on for those of you who are in clinical the second 8 weeks. This is just indicating head circumference where that should be measured, chest circumference, abdominal girth, and then that recumbent length, crown to heel. There's obviously differences in growths. We'll talk about sort of growth deviations when we get to the endocrine system, but there definitely is differences. Yeah, when we're doing measurements, we're always sort of comparing that to normal values for age groups, and and also for children that have different maybe syndromes or may have other developmental delays, um, there are some growth curves specific to those syndromes or things like that that we actually plot them on those so that we know, well, you know what, they're shorter than normal, but actually they are appropriate for their age given their diagnosis or syndrome that they have. Okay. Measuring vital signs. There are levels in your book. You don't have to memorize these, but I do want you to be familiar with what's normal. If we see a heart rate of 100 on an adult, we're a little bit worried. If we see a heart rate of 100 on a 15-month-old, we're not that worried. That's pretty normal. So keep this in mind when you are looking at vital signs in the clinical setting and when you are thinking about things that might be wrong with a child. We have to look at vital signs that are appropriate for their age. Measuring temperature, either axillary or you also may have a tympanic. In the hospital, you have a temporal, which is going to measure across the forehead. Cuff selection is critical in measuring pediatric blood pressures. Okay. Cuff placement is also critical because you may get an abnormal reading depending on if you have the wrong cuff size or a wrong placement. So pay attention to that as well. Okay, physical assessment is basically the same as adult assessment, so I'm not going to go through this very much. That's review. All right, that's chapter 6.